Hi, everyone.
Hiya.
Thank you so much for joining our Advances in Autism Research and Care webinar. We took a summer hiatus, which some of you may know, so we hope everyone enjoyed their summer. We're really excited to start back up this fall and into 2019. So we have some really awesome presentations to look forward to in the coming months. Some housekeeping things. If anyone has a question at any point, there should be a little questions box on the right side of your screen, so you can just type that in there, and I'll be able to ask at the end of the presentation. And if you have any chat questions or comments for me or for the entire group, you can feel free to type anything into the chat down at the bottom. This will also be recorded and sent out in the post-webinar email, and it's going to be posted on our network's YouTube page if you want to share it to people who weren't able to join today. Without further ado, I'm going to welcome Dr. Karen Kolthow, who's our network principal investigator, and she's going to welcome our presenters for the day.
Hello, everyone. This is Karen Kolthow. We are delighted to have Dr. Ben Handon and Eric Buder present on parent training for disruptive behavior. Dr. Handon is a professor of psychiatry and pediatrics at the University of Pittsburgh School of Medicine and Director of Research and Clinical Services at the Center for Autism and Developmental Disorders at Western Psychiatric Institute and Clinic. Dr. Handon is a clinical psychologist with over 30 years of experience in the field of autism and developmental disabilities. He is also the PI of the University of Pittsburgh Autism Treatment Network site. Among other things, Dr. Handon's research is focused upon the examination of psychopharmacology and psychosocial treatments in autism spectrum disorders. And I'll introduce Dr. Buder as well. They will provide an integrated presentation today. So Dr. Buder is a clinical psychologist with a specialization in autism spectrum disorders, ADHD, and other neurodevelopmental disabilities. Dr. Buder's research is focused on the biomedical correlates and potential etiologies of autism spectrum disorders and ADHD, as well as psychological and medical treatment of these disorders. He is an associate professor in the Department of Pediatrics and Psychology at Ohio State, and he is also the chief of psychology at the Ohio State University Department of Pediatrics at Nationwide Children's Hospital, and the director of Clinical Developmental Center and the Department of Pediatric Psychology and Neuropsychology at Nationwide Children's. You can see we have a very esteemed group of presenters, and I'd like to welcome them and thank them for presenting, and enjoy the talk. Thank you.
Hey, thanks, Karen. So this is Ben Handon, and I'm going to kind of start things off.
I'll just say hi, this is Eric.
And Eric will be jumping in, and we'll be interrupting each other, and hopefully it'll make some sense. So we're glad you could join us. We're going to be talking about behavioral interventions for young children with autism. Let me first just recognize that a lot of this research came from something called RUBI, which stands for Research Units in Behavioral Intervention. It's part of the Autism Network. This is our group of our collaborators, Larry Scahill at Emory, my colleague Cindy Johnson, and myself. Cindy's now at Cleveland Clinic. I'm still here at Pitt. And Luc Lecavalier, Mike Amen, Eric Buder at The Ohio State University, Naomi Swazi at Indiana University, and Karen Beers, who was with Larry at Emory, is now at University of Washington. And we would like to recognize our colleague Tris Smith from University of Rochester, who unfortunately passed away unexpectedly last month. And Eric was kind enough to pull some pictures together. We really miss him. He was really very inspirational and an integral part of all the work we've done, really, for the last 10 years or so. There's some current pictures, and before I knew Tris, but he has a lot more hair than I do.
It's particularly poignant. Tris was planning to do this webinar with us, so it's appropriate that we think about him and honor him during this hour.
And we just want to acknowledge our funders for the Ruby Network, which includes funds from National Institute of Mental Health, and looks like some local funding as well. Great. Okay. So here's what we thought we would do with you this afternoon. Really 3 things we'll be covering. I'll talk a little bit about the rationale for a parent training model, and then together Eric and I will take a few minutes to kind of go over the structure of our Ruby parent training program, and then Eric will take over on his own and talk about some of the research that we've done and share some of the outcomes. And we'll have time for questions as well. So first we want to just kind of give you a little background about why we would even want to have a parent training model of treatment for children with autism. So just to make sure everyone's on the same page, just a reminder that in 2013, the DSM, the Diagnostic Statistical Manual, was upgraded to DSM-5, and we now refer to autism as autism spectrum disorder. Not too much has changed, some of the terms, but essentially we still see autism as including deficits in social communication and social interaction. It typically includes restricted, repetitive patterns of behavior. These are symptoms that we typically see in early childhood, though there's a recognition now in DSM-5 that sometimes those symptoms become more apparent as children get older and the bar raises in terms of social expectations. So sometimes we don't make the diagnosis until early teens or even early adulthood in some cases. And we do know that the symptoms are expected and typically do impair everyday functioning. A little more background, as most of you probably know, we think that it's about a male to female ratio of 4 to 1. And the number of children within the spectrum who also have intellectual disability are somewhere around 30 to 40% seems to be our current estimate. Another point that some people may not be as aware of is that we typically see impaired daily living skills that's not explained by intellectual functioning. So by that we mean that we might have a child who intellectually might be functioning, say, at a 6-year level, but their daily living skills may even be below that, where we would expect someone who's functioning cognitively at a 6-year level to be able to do things that a 6-year-old would be able to do. Adaptively may actually be more functioning at a 4 or 5-year level. So there's that unexplained additional delay. We have a good number of youngsters and young adults who have seizure disorders. It seems to be bimodal. There seems to be a group in the younger age, and then there seems to be another group, usually late teens, early adulthood, who begin to develop seizures. And as most of you know, there is a well-documented high rate of serious behavior problems, including hyperactivity and anxiety in the child autism population. Okay, so the behaviors that we're typically concerned about are what we call disruptive behavior, and that occurs in probably half of children on the autism spectrum. This can include aggression, tantrums, severe hyperactivity, things like that. We also know that ABA techniques, or what we call applied behavior analysis, have been around for decades, and that we know that they are excellent in terms of how to assess behavioral concerns such as disruptive behavior, and that there are many behavioral techniques, ABA techniques, that have been shown to be very useful in treating these types of behavior. But the problem is that there's really not a lot of guidance on exactly when, why, or how to use these techniques in practice. And while we've seen them used, and there's a lot of research in individual children and very small groups of children, the techniques haven't been evaluated in large groups of children, dozens and dozens, even hundreds of children together. So that's kind of some of the background here. So in thinking about parent training, why do our families need treatment is probably our question. And I think the answer should probably be obvious to everyone, but just to review, obviously having a child who has autism spectrum disorder, especially one who has a lot of disruptive behavior, can be a significant burden on a family. In fact, there's research to show that parents of children with autism experience higher levels of stress, higher rates of depression than certainly we see in families of typically developing children, and even children with intellectual disability but without autism spectrum disorder. One of the challenges is we also know that children with autism have a lot of difficulty generalizing their skills and their behavior. So they may be very manageable in terms of their behavior at school, but things could be very problematic at home. So as we kind of have in the slide, quote, no problems at school, a lot of our parents have been told that. And I've seen that oftentimes in my practice, the opposite, where a child has many problems at school, but the parents say, you know, we don't have any problems at home. So this generalization, being able to follow rules and behave appropriately across environments and to use the skills that you've learned across environments is hard for our kids. And many families, use what we call some accommodations, for good reason, because it's just a lot of work, especially if there are other children in the family, to kind of be teaching every moment and have programs in place every moment. And so sometimes it's just easier if you have to get 3 children out in the morning to school to just dress the child rather than to take the time necessary to really teach dressing skills. It may be easier to mash food rather than to deal with food sensitivities, which also takes a lot of time. So these are some of the reasons that, our families probably, in our mind, need to be involved in treatment. There's some other challenges to treatment. First of all, doing a lot of the intensive behavioral interventions is very time-consuming and personnel-intensive. And so as a result, it's very challenging to disseminate these kind of interventions across the country. It's hard for many families to access, especially families in more rural areas. And so there really is a pressing need for studies that will come up with ways to expand the availability of what we call empirically supported, time-limited, really short-term but cost-effective treatments for children on the autism spectrum. So with that in mind, probably, I don't know, Eric, 15 years ago, it's been a long time since I thought about when we started this.
All right.
Yeah, probably had. It was probably 2003, 2004. We began thinking about parent training as something that really was worth devoting a lot of research effort to. And first off, even 15 years ago, there was a long history of the use of parent training within the general population of neurotypical children. Even now, at least 30 years of vigorous research, oftentimes focusing on kids who had what we call externalizing disorders, such as ADHD or oppositional behavior. And there are a number of models. Some of you may be even familiar with them. There's just 4 that have been around for some time. Kasdan method of parenting, the Iberg parent-child interaction therapy method called PCIT has been around for at least 25 years. Russ Barkley's Defiant Children program, again, for typically developing children, and Webster Stratton's Incredible Years. So parent training is not something we certainly came up with. It's been around for some time. And in autism, parent training is oftentimes part of other programs. And some of them are exclusively parent training. So here are some examples. Stepping Stone, Triple P. Eric, I think you're a little more familiar with this program than I am. I know that the Early Start Denver model, which is a kind of intensive early intervention program for children, the traditional model involves about 20 hours a week of one-on-one by a therapist with the child, but it also includes an additional 5 hours a week of work with the parents, where the parents are expected to provide work with their children. So parent training is part of the Denver model. Pivotal response training oftentimes includes some parent intervention. The LEAP model which was started here in Pittsburgh, the TEACH model, which was started in North Carolina, and preschool autism communication trial. So one thing I would say about these is, while most of these interventions are focusing on skill development, communication skills, play skills, social interaction skills, those core features of autism, they don't necessarily focus on the disruptive behavior problems that typically get in the way of developing those skills in those areas. Let's try the next one, Eric. Okay, so when we first started thinking about parent training 12, 15 years ago, our rationale, it really didn't require a lot. It seemed pretty obvious. There was lots of empirical support, lots of research evidence in the applied behavior analysis literature in autism that this made sense. There were lots of what we call single subject or very small studies that showed, surprise, surprise, that parents can learn ABA techniques. Of course they can. As we already said, most programs that were intensive already included a parent training component, so this was nothing new. We saw it as something that was very cost effective if you just focused on the parent piece. And one of the things that made it potentially cost effective was that it could be implemented in community-based practices. It could be in rural areas, it really could be anywhere. And the problem was that trained ABA therapists are not all available all the time, but parents are. They're there raising their children, most of the time. So they're the clinicians who are there to work with the kids. So that was the rationale. And so what we did is we developed a parent training program. Originally, it was part of the RUP program. And I think I talk about that in the next slide. We give you a few acronyms here, which will be confusing. The focus, as I said, rather than a lot of work on skill development, though our program does include skill development, the real primary focus is on addressing disruptive behavior. And the first group that did this was called the RUP group, which stands for Research Units in Pediatric Psychopharmacology, Autism RUP. And in the early 2000s, a group of us, including Eric and myself and Cindy Johnson, developed and piloted a manual for disruptive behavior in mostly school-age children with autism. Eric, I think we went down maybe to age 5. I'm trying to remember. It's been a while.
I think it might be 6.
6. Okay, so it was like 6 to 14, 6 to 12. And then we followed that by adapting the manual for use as solo treatments. Originally, it was the original study with this parent training manual was done with a drug called risperidol. You may know it as Risperdal, which is a treatment for highly disruptive behavior in children with autism. And we compared parent training with this drug. And it seemed to work very well in combination with the drug and improved the outcome versus drug alone. And so we decided, a subgroup then decided to develop the manual as an independent solo treatment without the medication for young children, for preschoolers with ASD. And another group of us that I led also adapted the manual for school-age children who had ADHD, who were on the autism spectrum, and we looked at that in combination with a drug called Strattera. But the rest of our talk, we're really going to focus on the school-age version of that manual, which is called the Ruby manual, and we tested it in a preschool study, which we will be talking about. So, in our next slide, this was our first manual. It was published in a journal called Behavioral Interventions way back when I still didn't have any hair, but it was 2007. And the first 3 names, well, many of these names are the same names that we showed you earlier. So Eric's going to join me, and we're going to kind of take a few minutes and kind of go through what this manual looks like. You want to start us off, Eric?
Sure. So our manual hasn't changed very much over the 15, 17 years that we've been working on it. At the core, there are 11 sessions that take you through a curriculum in a pretty sequenced and structured way, starting with the basics of behavioral intervention. How do you assess behavior problems? how you think about the stream of behavior, the three-term contingency, antecedent behavior, and consequences. Then we move into talking about prevention strategies. The best intervention for a behavior problem is preventing a behavior problem from ever happening, is the theme of those sessions. And then we also recognize that schedules and transitions are difficult for children with autism especially, and it's something that is uniquely applied in this intervention because we are focused on children with autism spectrum disorders. Changing behavior through reinforcement, increasing the kinds of behaviors you want to see long-term is far more effective than trying to punish behaviors. And so we spend 2 sessions talking about reinforcement. A lot of behaviors are maintained because of the attention they get. There's a tried and true technique, but it's probably one of the hardest techniques you try to implement with any family, called planned ignoring. And we feel like we have a pretty successful session focused on ignoring. Building compliance, a habit of compliance is just like any other habit. If you don't have it, you got to practice it. And so we have a session committed to focusing on compliance training. We recognize that autism comes with communication deficits, and there's a session dedicated on building communication skills, but specifically functional communication skills, how to help children get what they want by using communication rather than behavior. And then we also focus on building new skills, daily living skills or academic skills or social skills. Really, the parent drives what kinds of skills they want to teach their child. We teach them how to teach in 2 sessions called teaching skills. And then we also ask parents to think about long-term, how do they generalize across settings and across people, across different behavioral domains, and how do they maintain successes. It's always been a part of, go ahead.
I'm going to say each of these sessions is about an hour to an hour and 15 minutes in length.
Yeah, and we had, in the research trials, we've always done home visits. And there's also been room for us to do telephone calls to help boost parents after the 11 core sessions are done, longer term out. But I'll let you say something about the optional sessions if you like.
Sure. I'll also mention something about the home visits. We really like those because, you know, in the years of working with parents in an office, you know, it's hard to vision what the home looks like, just to walk in and see where the bedroom is and where the bathrooms are and how the layout is. It just makes it a lot easier to help parents kind of figure out how to rearrange schedules and organize the house. So, but then we had 7 optional sessions because, as you can imagine, every child is different, every family is different, and as a result, their needs are different. And so sometimes we felt like we needed to have the ability to focus more specifically on a certain area. And over the years, we kind of developed these optional sessions to include toilet training. A lot of kids had feeding problems. Sleep problems were a very big session that was used frequently. Timeout for kids who it was appropriate for and necessary, we would have a session on that. Some of the kids really who needed to develop many more basic skills might need to start with imitation skills, and so we had an imitation session. For research purposes, we even had a session on crisis management because, surprise, surprise, parents sometimes came in and there was a crisis at home. Someone was sick, someone had passed away, the family lost had to find a new house, something happened, and we needed to kind of go into crisis mode. So we wanted to provide some structure for our clinicians. And then finally, for some of the higher functioning kids, we went into contingency contracting, how to even write a contract with some of our kids.
And then, of course, since we were designing a program specific for children with autism spectrum disorders, there were some unique aspects to this parent training program that really allowed us to treat children with autism in a way that using one of the off-the-shelf parent training programs that already existed for disruptive behaviors didn't, including visual strategies were incorporated into our sessions. The parent materials were really focused on identifying functions of behaviors. The idea was always to teach families where is this behavior coming from, what is the root of it. We emphasized the functional communication approach, recognizing the communication deficits often present in autism. There was an emphasis on decreasing behavioral excesses, for sure, but also on skill acquisition. Once you are able to decrease a behavioral problem, the best way to keep it gone is to teach a new replacement skill. And then a focus on generalization and maintenance, as we know that generalization can be a challenge for children with autism.
So the sessions had a number of components that are in many ways nothing unique to autism, but they included didactic instruction. We clearly had content that we wanted to relay to parents. We had a lot of demonstrations happening by the clinician and had some video demonstrations of models that we'll show you some examples in a second. We tried to do role plays, the clinicians playing the child. Sometimes we had the child in the session so that we could coach the parent and demonstrate how to do the intervention with the child. I'm not sure whether parents like this part, but we had homework. It was usually developed together, but clearly that was when the parent had a chance to practice these skills and bring back the information to the clinician so that we could give feedback and help problem solve, which is what we did in the next session. And then we would pull everything together as we were going along and develop this plan so that at the end of 15 sessions, 16 sessions, we had a well-designed behavior support plan.
One of the things in parent training programs that you want to be certain of is that you are delivering the content as designed, but you want to make sure that you're as flexible in your process as possible to meet each individual family's needs. And so we were trying to balance between flexibility and standardization. We addressed the need for flexibility by really recognizing that no two children with autism are exactly the same. They're children first, and no two children are the same. And autism impacts every child a little bit differently. And so there's great heterogeneity of children with autism, and our manual tried to reflect that. We also recognize that every family and every set of parents have very different needs. And so the manual really allowed a lot of room for parent input into the kind of work that we were doing. We also gave our therapists some flexibility. Though there is a designed order of intervention, the order that we showed you on the previous slides, the truth is that our therapists could change the order based upon the family's needs and the child's behavior and their progress. And so this really allowed, at least in the context of the research study, or the various research studies that we did, it allowed our clinicians to come to our cross-site clinical panel and say, I really like to do timeout right here, rather than move forward with a teaching skill session, for instance. And we are encouraging people in clinical implementation of this parent training program to do the same.
So one of the aspects that we were very excited about, though I have to say we didn't make this up, we borrowed this idea from another parent training program for preschoolers, is to use video training vignettes. And we use these to depict some of the common behavioral challenges that we expected our families to experience. And it was really a way to supplement our direct instruction. And the model, the way we did this is we actually had videotapes of a parent or an actor as a parent doing flawed parent management strategies where there were clearly errors. And it was up to our parent in the room with us to help identify what was the error and really provide some suggestions about how to correct that error. And it was a way for us as clinicians to get a sense of how well did the parent we were working with understand the concepts that we were talking about, and had they actually at least understand it well enough that they could see if someone was doing it wrong. So Eric will probably introduce this example.
I do have an example. I hope the sound works. If it doesn't, I'll try to fix that. Oh, yeah, let me fix the sound, folks, because we're not hearing the sound. So let me pause there. I turned the sounds off on my computer because of the need to not hear all the dings, but let me fix that. And I will go back to showing. Forgive the little technical interruption here. All right, so we will start over.
Come on, buddy. Got some errands to run. Come on, get your shoes and your coat on. Come on. Come on, let's go. Hey, come on. Listen to me. We got to get going. Mommy's running late. Stop that, all right? If I help you put your shoes on, will you put your coat on? Come on. Come on. Mom, let's let you put your shoes on. Okay, come on. Hey, I gotta go. I don't have time for this now. Sit up now. Sit up now. Come on. Come on. Come on. You get your coat on, all right?
So this is one of dozens of videos that we use, and this video comes from our prevention session, with the goal being to help parents identify what could this mom do to prevent this problem from ever happening. None of us like to be told to stop doing something we really enjoy doing, like watching our morning cartoons or playing a video game, to go do something we really don't want to do, put on our coat to go on a school bus. So the better approach here might be to potentially just change the environment, have the parent turn off the TV or have the child turn off the TV before they attempt to get dressed. Or maybe even a better approach would be to change the order of events. Have the child be essentially ready for school, maybe even with his coat on, while he's watching his 5 or 10 minutes of cartoons before he goes to school. And the goal here is, earlier in the session, we would have reviewed a variety of potential prevention techniques with the parent during our parent training session. And then we would show this video as a way to continue that discussion and to help the parents see how they can apply the content. And ultimately, at the end of the session, have the parent design a prevention technique for their child for the next week, and that would be the homework assignment. Anything to add there, Ben?
No, it was great. I love seeing those vignettes.
All right.
So because we're a little moving along time-wise, I'll just mention briefly that in our research studies in parent training, we clearly did a lot of supervision of our therapists and watched many videotapes of our therapists doing sessions to make sure that everyone was literally on the same page and following the protocol correctly, which is fairly standard in research studies.
And I would say that our treatments were generally delivered as we intended them, and our parents were very adherent. And so you'll see some of that data here in a minute from our largest trial. All sessions, again, were videotaped, and we had these fidelity checklists that really showed how parents were and the therapists were meeting the goals that we had for them for the session. Maintaining fidelity was really important in the research studies. We had weekly site supervision. There was monthly or even sometimes weekly cross-site teleconferences where we shared information between sites. Our parent training program is really a detailed script. You can pick up the manual and read word for word what you're supposed to say to the parent in session. Of course, we hope therapists don't do that now, that they don't just read directly to parents. But the idea is there's nothing left to the imagination. You knew exactly what we want you to do when you pick up the parent training manual. And the idea is that you eventually find your own words for it, but that you really do follow the content as closely as possible. And these checklists are available. Essentially, this compliance training session, treatment fidelity checklist, shows you exactly what we do. I'll just highlight a couple things. The first goal would be to review homework from the prior session. The second goal would be to demonstrate a play session with the child, because that was something that you reviewed in the previous session. And so if the child were present at the next parent training session, this one, you would actually go ahead and demonstrate it and model it. But then you move into the content of this current session that's on compliance training and so on. And you'll notice there at goal 11, you would wrap up and give the homework assignment for this next week, which would be a compliance training assignment. And I'll let you talk about the final parent training manual.
So we finally pulled the parent training manual together. And we have it as an introduction with case examples and tips for clinicians. And then the 11 core sessions and 7 optional sessions are there with a therapist script, with activity sheets, because there are activities that are done with the parent, and so in each session. And so we have those sheets available. There are handouts that parents can take home with them that kind of summarize what the session was about, since it's a lot of material to take in. And then the fidelity checklist that Eric just talked about. There are forms for a home visit and forms for booster sessions. And so we first, I guess you would say, self-published this, Eric? Is that what the term is? while we were negotiating with some possible publishers.
The manual is now available pretty much from any bookseller. It's part of the Oxford University Press Treatments That Work or Programs That Work series. Oxford has published the clinician manual and has a parent workbook. It's roughly, depending upon where you buy it, you might get it at Amazon a little more cheaply than at other places, but the clinician manual, I think, is around $49. So it's relatively cost effective, and again, you can do this just by picking up the manual if you're a clinician. The other thing that's coming out is a book that describes the work that we've done in a broader way, a more academic text that covers parent training for autism spectrum disorders across a variety of topics. You see many of the same authors that have been a part of this parent training development work are also authors in this upcoming book that will be published in just a few weeks from the American Psychological Association. This is less a book plug and more just to say that there might be something here for all audiences, clinicians or other researchers or people who want an update on where the state of the art is in parent training right now in autism spectrum disorders. This volume from the American Psychological Association might be for you. I'll transition and I'll try to be pretty quick about this because there are a number of slides that talk through what really was our largest research trial. This project was published in the Journal of the American Medical Association in 2015 with the title Effective Parent Training versus Parent Education on Behavior Problems in Children with Autism Spectrum Disorder. This is a randomized clinical trial where we were comparing groups of children who received this parent training program to children who received a parent education program, where the goal wasn't to change behavior, but really to impart information to families about autism spectrum disorder. The study design was really geared toward evaluating whether parent training would be superior to parent education. We were specifically looking at irritable behaviors, tantrums, noncompliance, aggression, self-injury. It was a 24-week trial, and at the time, and still technically is, the largest randomized clinical trial in autism spectrum disorders. There's about to be a larger one published. This had 180 preschool children with autism spectrum disorder randomized to one of the two groups. Our study design basically focused on children 3 to 11, so 3 years to 7 years old, essentially, and kids who were irritable but not very irritable. We used the Aberrant Behavior Checklist irritability scale, and that score says that they have a certain amount of irritability that's too high to be comfortable with managing without some support, but not so high that it was dangerous to put them in the study. Exclusion criteria were children who had receptive language levels below 18 months. We randomized across sites and made sure that we had just as many parent training as we had psychoeducation at each site. We had an independent evaluator who's blinded to treatment, which meant that they did not know which group the child was in when they were rating scales. Our outcome measures were really focused on primarily on tracking whether or not children became less irritable and whether they became more compliant. So the Home Situations Questionnaire and the Aberrant Behavior Checklist measured compliance and irritability respectively. We had a secondary outcome measure that we thought was pretty important, and this was the clinician's sense of how well things were going. When you go see a doctor and you tell the doctor how you've been doing, the doctor makes a judgment. Gee, I think you're improved, or no, I don't think you're improved, and you could probably use some more help from me. Maybe I'll add a medication, or maybe I'll tell you to do X, Y, or Z. We try to capture that sense of improvement or lack of improvement with something called the Clinical Global Impression Scale. The CGI, as we refer to it, is rated by the independent evaluator and tries to capture the whole sense of how the child's doing. We also tracked adverse events, and we were paying attention to a range of other outcomes in the study. In terms of how these programs stacked up against each other, they both were 24-week protocols. The parent education program, our control condition, focused on 12 core sessions and 1 home visit. And so our parent training program did have a lot more, but we really did try to control for the amount of attention that families were getting between these studies. And so we thought in the end they were pretty equal. This shows you how children moved through the study. We screened more than 250 kids. About 87 children were excluded, mostly because they didn't meet inclusion criteria. Overall, we randomized 180 kids. 89 received parent training and 91 received parent education. We had very limited attrition in this study, and it wasn't differential between groups. And we really did analyze all the children that came through the study. Our baseline characteristics. Most children in the study were boys. The mean age was about 4.5. This was a group of kids who did not have a high level of intellectual disability. 74% of the sample had IQs above 70. It was a largely Caucasian white sample. We were still using DSM-4 criteria when we enrolled in this study, so 69% of the children had autistic disorder. 46% of the kids were enrolled in regular education classes. That probably, again, parallels the intellectual disability status that we had in this study. And 20% were on stable psychotropic medication, so most kids weren't on medication. This gives you a sense of how the groups stacked between each other in terms of the amount of irritability. The groups were pretty equal. In terms of the amount of compliance, they were fairly equal. So there you see scores in each column that represent the equity between the groups. The violent adaptive behavior scales measure how well a child is doing in their everyday life, applying the skills they have. How well do they move through their everyday life? A score of 73 versus 76 is not meaningfully different, and those scores represent significant impairment in what we call the borderline range of functioning. And then you see the CGI scores here. Again, generally equivalent between groups, from moderately ill to markedly ill, severely ill, whether you were in the parent training group or the parent education group, our groups seem to be enrolling the same kinds of kids. And here you see some outcomes. This is the parent-rated irritability scale from the Aberrant Behavior Checklist. And at 0 weeks, that's baseline when we entered the study, as you saw in the previous slide, our groups were largely equal. By week 24, our group separated. The parent education group was significantly more irritable. Children in that group were more irritable than the children in the parent training group. So parent training seemed to reduce overall irritability in children whose parents were enrolled in the parent training group compared to those enrolled in parent education. If we look at compliance, or what we measured using the home situations questionnaire, again, you see that the groups were similar, equal at baseline at week 0, but by 6 months later, at week 24, there was separation between our psychoeducation group in red and our parent training group in black. We saw much lower levels of noncompliance. And then here you see the clinician's impression, hearing all that they can from the parents about how their child is doing, taking in all the information that they know about how their child is doing. Do the clinicians see parent training as being superior to parent education? The answer is yes. At week 0, at baseline, you see that there is no separation. By the time you get out to week 24, 6 months later, our clinicians are seeing a significant difference in the overall improvement of kids who were enrolled in parent training. Our treatment was delivered with fidelity. Both parent training and parent education were delivered by 23 therapists across 6 sites. That's pretty robust. A lot of different people and a lot of different places around the country doing this. The number of cases per therapist range from 1 to 21 cases, about 7 each was the mean. And treatment fidelity was excellent, with mean ratings of way above 90% in both groups. So we delivered the treatment the way we designed to do it. And we follow these kids all the way out to week 48. So this is long-term follow-up. How well are we doing? Here you can see children who have had a positive response to parent training and children who had a negative response to parent training. And essentially the question is, did this sustain? And the answer is yes. For both irritability and compliance, there's a slightly more nuanced story here, but the real take-home message is that the effect generally sustained for parent training. If you didn't do very well, it was really stable. If you did do very well, it was also stable. Long-term outcome, parent training, positive responders, 79% maintained their positive response at long-term follow-up. That's pretty impressive. For parent training negative responders, those who didn't respond initially, there seemed to be a slight sleeper effect. They seemed to improve by week 48, at least 32% of them did. Here is a real interesting outcome for us. There were children who had our control condition, again, a condition that was designed to not necessarily change behavior. The psychoeducation positive responders, 70% maintained a positive response long term. So this is really a powerful statement for how well parent training worked, because our psychoeducation program also worked. And so for us to have a significant effect for parent training above and beyond what was already a very active and positive control condition was a very rigorous test for the parent training program. So a few points to keep in mind. This is the largest psychosocial randomized clinical trial in autism ever done. Parent training was more effective than parent education on parent ratings of disruptive non-compliant behavior, and by a overall improvement rating by our blinded clinicians, and the gains were maintained 24 weeks post-treatment. As I said, random assignment here was to parent training and an active comparator, a comparator that actually was itself an effective treatment for kids. We had blinded clinician assessment of outcome, we had long-term follow-up, and we had really, really high fidelity in what is a pretty complicated multi-site trial. This sheds very, very high promise for dissemination and implementation, which I'll talk about quickly here in a second. There were some limitations. We relied heavily on ratings from parents who weren't blind to treatment assignment, although our CGI, our clinician rating, was blind to treatment group assignment. It did rely upon parents' discussions of how their child was improving, and the parents knew what treatment they were in. We worked really hard to make sure the parents didn't tell the blinded rater, however. The results reflect benefits of parent training under what we think is really optimal conditions, well-trained therapists, independent evaluators, a very selected sample. Would this work in the real world is the question. If you're interested in seeing more about what Ruby is doing, if you're interested in training in your area, you can check out the rubynetwork.org website. But let me just say a little bit more about implementation. There's a group of us pioneered by Karen Beers, who's currently at Seattle Children's, who are looking at how well can we do a clinical version of Ruby. Once you take it into the real world, is it still effective? So again, I'll be quick here to save a little bit of time for questions. Essentially, when we try to move evidence-based treatments into the real world, they don't move easily. It's estimated that it takes about 17 years to move an evidence-based treatment into clinical practice. And even then, does the treatment actually reach people who most need it or underserved populations? The answer is no. So even when it gets out there, there's no promise that the treatment's really going to work for lots of reasons. And you see some of those reasons there. Primarily, translating what it was a effective treatment in a very controlled research setting to clinical cases with all the messiness that comes with real-world situations can be challenging. Some of those challenges, there are different child factors that maybe we didn't have to deal with. Children are differently motivated. There are a range of comorbidities that we might have been able to control for in our research. Problems wax and wane and flux and go up in time at one time and go down in another. There are real-life factors that, again, in our selected sample might not have been there: poverty, trauma, violence in the community, child maltreatment, placement changes between caregivers or schools, kids dealing with bullying or taunting from their peers. There are therapist factors. Again, we use therapists who had the opportunity to be well-trained and to be talking to each other on cross-site calls weekly and monthly near the end of the trial. We were able to control their caseload. Our therapists were probably under the most ideal conditions. There are family factors in the real world that maybe we didn't have to deal with. You can see a few of them listed there. You saw that we had a very low attrition rate in our study that does not mirror what happens in real world clinical practice. And then there are a range of clinical factors that can happen in the real world that just really prevent you from implementing exactly the way you did in your research study. So Ben said our sessions could last 75 minutes, sometimes 90 minutes. In the real world, you're going to be scheduled for an hour, and the clinician's going to bill for an hour, and that's all you're going to get is an hour. And so it's going to be very different. So when you think about what we're trying to do in a implementation, we have to deal with all these different factors and recognize that we may not be working under those same highly controlled conditions that we did in the research trial. There are some things that said Ruby probably held promise for implementation, and one of them was that just how strong our comparator was, and that Ruby did better than it. There was a 39% positive response rate to our psychoeducation program. Our control condition, kids really responded to, but yet we still garnered a really strong effect size of 0.62. We did pull from clinically referred samples, so even though we didn't have a tremendously diverse sample in terms of socioeconomic strata or racial and ethnic minority status, we were pulling from clinic referred samples. But in the end, we did control who got in, and we did make sure our therapists were well trained. So will Ruby work in the real world? And we have some preliminary data from our consortium. The consortium right now includes Marcus and Seattle Children's, Nationwide, and the University of Rochester have also participated. The data I'm showing you is from a 2017 presentation at a national conference. And in short, the answer is we're pretty impressed. There are lots of differences between who's been enrolled in our research program. You can see there on the left side in gray versus the column that has the maroon heading, Ruby C for clinical, shows you what we're doing in the clinical implementation. It's just a little bit messier. We're expanding the age range. We're not doing a gold standard diagnosis. And we are sort of being more loose in who we're allowing into the clinical implementation. When you look at what we're doing in terms of thinking about Ruby Clinical, we don't care what medications kids are on. We're just, if they need parent training, they're getting enrolled. The therapist could be highly skilled or might be a new trainee, might be someone who knows a lot about autism or somebody who maybe is working very recently in autism. There are some natural exclusions that are coming up in the clinical implementation, and it's particularly around the more dangerous behaviors, things like pica elopement, things that are harder to treat with our program like encopresis, or very, very severe SIB. In the clinical implementation, like I said, the session length is about 60 minutes long. We're trying to do a 1-month follow-up. Patients, this is a clinical service. Patients are being billed, whereas in Ruby, they were paid to come see us. There was an incentive to offset families with the cost that it might have been for them to participate in the research. And then also children may be required to attend our sessions, whereas we, in many of our parent training sessions, didn't have children attend the sessions. Why they might be required in a clinical setting is because, depending upon the jurisdiction you're in, some billing requirements are written as such. So children come in for an intake, and we do a streamlined but standardized assessment. We initiate Ruby. We're generally doing the 11 core sessions and maybe up to 2 supplemental sessions. We take measurement at mid and end point, and then there's a repeated outcome about 1 month at follow-up. We're using a very streamlined battery, and you can see the assessment battery that we're doing here in terms of our clinical implementation. You'll see some familiar measures there, the aberrant behavior checklist and home situations questionnaire. This shows you data from Marcus and Ruby at Seattle Children's. This was, again, data from about a year ago, and we have about 100 families enrolled. And you can see that the group is older. The group has more comorbidities. The group is more intellectually impaired. The group is more racially diverse. And there's a wider range of kids on medications. These are the major differences between the kids that we had in research versus the kids that we have in the real world study. Attrition is still not as good, really. So, you know, in Ruby, our attrition was around 11%. And what we're seeing here are the kind of attrition that we typically see in real world clinical practice, somewhere between 20 and 30%. So families are dropping out of this treatment as much as they would drop out of any other treatment. But yet, and the moral of the story here is that you're seeing similar outcomes and effects. Regardless of how you break this down by site, whether it was at Marcus or was at Seattle Children's, we're getting decreases in irritability over time, and we're getting decreases in hyperactivity over time. We're getting decreases in noncompliance over time. Ruby seems to be working. This parent training program seems to be working in the real world under much more complicated circumstances than what was in our research study at about the same level was working in our research study. So I'll perhaps stop here and leave you with these conclusions. we are showing preliminary data that really does show a powerful impact for Ruby, both as a research driven parent training program, but also one that can translate into clinical practice. There's a lot more work to do here, and we're hoping to do more work and potentially even more work with ATN sites ultimately. But we're really eager to see families do well by working with a clinician to learn how to manage difficult disruptive behaviors among their children with autism. So I'll stop there, and we have just a couple minutes. Megan, I don't know if there's any opportunity to try to answer any questions.
We lost Megan.
We lost Megan. Well, given we're at the top of the hour and we don't really have an opportunity we don't know how to run the chat or the questions.
Yeah, this is Karen. I don't think I can see, I don't see any questions, and I may be blinded to them. So I would just like to say thank you. It was a super interesting presentation, really appreciate it. And if people have questions, they can chat them into the webinar. So thanks so much.
Thank you. Thanks for the opportunity to speak to you all.
Take care.
Bye-bye.